Hi, my name is David Ryley. I'm a infertility specialist, more officially called reproductive endocrinologist and infertility specialist at Boston IVF. I work in Boston IVF's downtown office, but we all work together as a group dedicated to helping individuals build their families. And so we're here today to address any questions that any folks might have about building their families and how we might help doing so. But it's not just about, advancing that cause. It's also about fertility preservation. Many individuals, for whatever reason, whatever personal, professional, or medical reason, may have to defer their childbearing or having a child or building their family to a more opportune time. And we do that as well. So I'm going to start answering the questions in both the Q&A and the chat room. And here goes. Let me just, for those who've seen me do this before, those who are maybe uninitiated, I'm a boomer. I'm not the best at technical proficiency, but I'm going to do my best. And Emily, who works in my group with me and helps run these, is laughing in the background. Okay, we have a question. Let me take a look at it. So the question is from, I will just quote it directly. I'm 40 with the polycystic ovarian syndrome and an AMH of 3.06. Okay, again, for those who might be uninitiated, the polycystic ovarian syndrome is a syndrome characterized by irregular ovulation, and it's the most common hormone imbalance that impacts women, all women, not just women who are presenting with infertility. Irregular ovulation is a very common cause of what we call infertility or subfertility. And this individual has an AMH of 3.06. AMH is a hormone produced by all the follicles or eggs. You'll hear me use those terms interchangeably. And that's a hormone that reflects how one might respond to treatment. I want 2 children. I just got one embryo that was PGTA normal from the first round of IVF. Again, for those who are uninitiated, PGTA normal means the genetics or chromosomes, the way that embryo's DNA is packaged, reflects that it is high quality with a high implantation potential and a low rate of miscarriage, and the event is used. Should I do more IVF now to get more embryos? And if so, how many should I have for a second child? My doctor is pressuring me to transfer now due to my high reserve, and I am wondering if I should get a second opinion. Second opinions are not warranted here. I think your doctor's advice is just that, his or her advice. When you're looking at building a family, you're looking at age issues and individual plans. And many individuals are so ready to have their child that doing a cycle with that embryo, which has been frozen, is thawed, is the right way to go. It's time to get pregnant because that individual is so ready. If that individual at age 40, not an uncommon scenario, would like not only to optimize their chance of getting pregnant now, plus build their family, it wouldn't be unreasonable whatsoever to do another cycle of IVF. I think if you got 1 or maybe 2 more embryos, you could have relative reassurance that you'd be able to build your family in the way that you're addressing here. I hope that helps. Is there a less invasive form of IVF that doesn't involve taking medication, or is there one standard procedure? Well, the data would suggest that the optimal way, by far the optimal way to offer IVF is to take medication. So every month that a woman ovulates, okay, her pituitary gland produces a hormone called FSH, follicle stimulating hormone. When you hear me say follicle, think egg. And every single month, there's a metabolically active group of eggs, meaning a group of eggs ready to ovulate. And on that individual's own, without any assistance from medicine, the concentration of FSH they produce out of the group that's ready will get one to be released, and then all the others in that group will die off. So with IVF, what you're doing is taking the hormones And by so doing, you're saving those eggs from dying off. You're not depleting the egg supply. You're not causing future infertility. You're saving eggs. So that's why IVF works, and that's why the data shows that it works. If you were just to retrieve an egg to create an embryo, there's really no good data to suggest that without those hormones, you're doing anything different than any natural attempt at conception, meaning a procedure without medication, somewhat commonly referred to as mini IVF, in my opinion, has not been shown by any rigorous statistical analysis to be worthwhile. On the chat room, my first pregnancy test was 540 and my second was 1017. Should I be concerned it didn't exactly double in 48 hours? A rise from 540 to 1017 is great. Don't get so caught up, so to speak, in the numbers. It doesn't have to be an exact doubling, but that's well within the expectation of a successful implantation and developing pregnancy. So no, I would not be concerned. A lot of questions coming in. Is Boston IVF at patient capacity? It's a 1 month wait for a new patient appointment. I have no idea about capacities. I do know that summertime is always a time where it might be harder to get an appointment, but we have a lot of physicians and a lot of offices, and we offer satellite 21st century medicine, meaning Zooming like we're doing here. And unless you've been directly referred to a certain doctor, all my partners are really good. And those that might have an opening that is better for you, you could easily request that of our registration folks. So I guess my point is, we're definitely not at capacity, not at all. And we have plenty of doctors from whom you could choose. Why do women with the polycystic ovarian syndrome and endometriosis experience a higher miscarriage rate? What can be done to enhance IVF success in these women? Well, number one, the data is not clear-cut. And the data on the polycystic ovarian syndrome, whether one conceives naturally or through artificial reproductive technologies, the data isn't clear-cut that the miscarriage rates are higher. That being said, there is some data to suggest that individuals with the classic form of ovulatory function due to PCOS have perhaps egg quality issues, perhaps that might be impacting embryo development and might therefore be impacting miscarriage rates. So you want to make sure if one has the classic form of the polycystic ovarian syndrome, that they have lower blood sugar levels, a lower evidence that they are metabolizing their blood sugar well, and that's usually referenced through a blood test called a hemoglobin A1C. A hemoglobin A1C is a measure of how well one is metabolizing one's blood sugar, because there's always, not always, often signs of prediabetes in individuals with the polycystic ovarian syndrome. And data would suggest if the blood sugar is not being metabolized well, it might impact egg quality, therefore embryo quality, therefore incidence of miscarriage. So the best thing for any individual with the polycystic ovarian syndrome to do is to eat a well-balanced diet, see a nutritionist, exercise regularly, keep those hemoglobin A1Cs lower. That's the advice we all should get. It's no different than what our primary care physicians have said for years. Endometriosis is a complicated topic that we could have 20 lectures on and still be wanting more information and yearning for the answers to so many questions. There is some data to suggest that women with endometriosis, which is an inflammatory condition within the pelvis, which can impact fertilization. It can impact the ability of a fertilized egg, i.e. an embryo, to get into the uterus. And once in the uterus, the inflammation from that endometriosis might impact the ability of that embryo to implant or, in turn, miscarry. Again, the data is not perfect. Certainly, women with advanced stage endometriosis, the kind that required surgical intervention to resolve, you need to go through that surgical intervention to mitigate those miscarriages. When women with or individuals with minimal to mild endometriosis, where it's not so advanced, there's not great data that the risk of doing a surgical intervention is worth the benefit of either proving fertility or impacting miscarriage rates. I developed 2 uterine polyps after my 2 DNC procedures. What causes that? Is surgery the only option? I'm 29. Uterine polyps aren't necessarily part of infertility. If an individual has a uterine polyp or 2, and it's causing them to have dysfunctional bleeding, meaning they're not having regular menstrual cycles, they're having heavy menstrual cycles, yes, that would be associated with infertility, and their gynecologist, even if infertility hasn't been proven, should address those. Within the setting of infertility, polyps, which are these fleshy projections of material off the uterine lining within the cavity. So within the setting of IVF and artificial reproductive technologies, they may lower success rates. What causes them? Well, most of the time it's unknown and it's just seen. And likely most individuals with polyps aren't infertile and they get pregnant. That being said, some individuals, especially those who may be overweight, who have a classic form of what we've been talking about, the polycystic ovarian syndrome, might be predisposed to an overgrowth in the lining of their uterus, which could cause the polyps. So it kind of runs the gamut. Does it ever make sense to try intrauterine insemination between IVF embryo transfers? It's so dependent on the age of the individual and what type of embryo transfer you're referencing. So when you're doing an embryo transfer, that's the result of a thaw cycle, and therefore your ovaries haven't been stimulated. Yeah, you could do insemination, as long as we know that the individual who's undergoing the insemination has open fallopian tubes, because many individuals undergo IVF because their fallopian tubes are closed, or you want to make sure that the individual who's undergoing the embryo transfer, if they're going to do insemination after the embryo transfer, you want to make sure that the semen parameters, the insemination that you're using, the sperm used in that insemination is normal, because again, one of the reasons you do IVF is low sperm counts. I guess the point I'm trying to make is if you're doing a thaw cycle where you're transferring embryos that are frozen, yeah, you could do insemination as long as those other things are okay. Wouldn't hurt, because the ovaries haven't been stimulated. But if you're coming off a fresh IVF cycle where the ovaries have been stimulated, no, it would not make sense to inseminate, because the ovaries need to get back to normal. How do you balance hormones after having an IUD, no period for 9 months? So if an individual has had a removal of an IUD, but they now have what's called secondary amenorrhea. Amenorrhea means no periods. Secondary means they had them before. Irrespective of the type of IUD, whether it's the copper IUD, which doesn't cause one to stop having periods while the IUD is in place, or the Mirena type IUD, which does thin out the lining of the uterus and cause no periods. Irrespective of the type of IUD, if one has gone 9 months without periods, it's not due to the IUD. And there's a hormonal issue that needs to be investigated. There's many reasons why women don't ovulate regularly and therefore don't have regular periods. It runs the gamut from basically individuals who are of extremely low weight, extreme exercisers, and then the most extreme have an eating disorder, to the other extreme where they may have significant, and we've talked about it already a couple of times, polycystic ovarian syndrome, but the majority of individuals with this secondary amenorrhea, meaning lack of periods despite previous regular periods, the vast majority just having irregular ovulation. That would have nothing to do with the IUD. And about 2 months after that IUD is removed, one would expect normal, regular menstrual function. And if not, you want to have it investigated. And here I am looking at more. Which lab does Boston IVF work with for the PGS-PGT testing? Does the lab or Boston IVF determine which exact tests should be used on embryos? Okay, so much. So first of all, for again, the uninitiated, PGS and PGT is reflecting genetic testing of embryos. There's two types of genetic tests. One is where you're checking the chromosomes and how they're packaged, because you want them to be packaged normally. Chromosomes are where our DNA is packaged. And when they're abnormally arranged, they result in miscarriage or the embryos don't implant. There's also PGTM, pre-implantation genetication for mutations. So individuals who might be at risk of conferring a certain mutation and therefore a disease state to their potential child, they undergo that type of testing. So the question here is, which lab does Boston IVF work with? All of them. What dictates that? Well, the vast majority of the time is dictated by the insurance company, because the insurance company has a contract with that lab. So what happens is embryos are frozen, and right before they're frozen, we perform what's called a trophectoderm biopsy. So an embryo at that stage of development, before it's frozen, has met a certain stage where you can see the cell layers. One cell layer is the inner cell mass. The cells that give rise to the fetus, it's left alone. The other cell layer that makes up the mass of this embryo is called the trophectoderm. These are the cells that will develop into the placenta. You remove a group, the embryos are then frozen. So the labs that this individual is referencing, we send those cells out to those labs for that testing. The report comes back 10 days to 2 weeks later. We use every single one. They are all great. I don't endorse one over another. And therefore, you should feel very comfortable that the lab you use is a good one. If you're not limited by insurance necessities and you therefore get to choose the lab you want to use, I think the doctor's preference is based on whichever lab he or she has used the most. But I can promise you that all the labs we use are excellent, and we wouldn't use a bad lab. But I don't even know a bad lab that exists that does pre-implantation genetic testing, but it is most commonly dictated by insurance. What do you recommend right before and after an embryo transfer to try to maximize success? What I recommend is to try not to put that pressure on yourself. And what I mean by that is, I think the more one thinks, let's say one underwent an embryo transfer. So for those who have not had an embryo transfer, easy for a guy to say, it's a pretty routine procedure. Again, I recognize how easy it is for me to say. Think of it like a pap smear. We place a speculum in the vagina and we use an ultrasound that's placed on the abdomen as a guide. And we take this tiny plastic embryo catheter. It's placed in the cervix. So think of it like a pap smear at this point. And then you flush the embryo into the uterus and you see essentially the fluid that the embryo is contained where they're in the uterine cavity. And then you go home. And let's say, very unfortunately, that particular embryo transfer did not result in a pregnancy. Well, it's not because the individual drove home and hit a bump. It's not because the individual got up right away. It's not because the individual did or didn't have acupuncture. The point I'm trying to make is you don't have that level of control. And let me just reiterate that. You don't have that level of control. And for me, when my patients fret that they could have done something different, they're adding stress that they don't need to add, because that embryo, after it's transferred, is not going to implant into the uterus for another 2 to 5 days. And you don't have control. It's no different than a conception that occurs naturally. So for instance, during a natural conception, the sperm goes into the fallopian tube, it meets an egg, and that embryo, the fertilized egg, is going to be a day 5 embryo, otherwise known as a blastocyst, by the time it lands into the uterus, and it's still not going to implant for another 2 to 5 days. Well, we're doing the same thing. We're transferring the embryo into the uterus. So individuals who conceive naturally don't even know there's an embryo in there. And they're not putting themselves at bed rest. And they're not avoiding, hitting the bump on the way home from having gone shopping. So yes, I think a lot of individuals love the idea of relaxing, often utilizing ancillary services such as acupuncture, and they swear by it. And why do they swear by it? Because it makes them feel better. It makes them feel more relaxed. And there is data from only one study, but the data exists. I think it was back around 2002 to suggest that acupuncture pre and post transfer enhances success. That data has never been replicated. And so if one feels good and likes doing it, go for it. But I don't want anyone to ever feel that there was a lack of success because they didn't do it. So I think that puts a lot of pressure on oneself. If I have fibroids, what criteria would you use to determine if surgery is necessary? Well, it's a great question. Again, for the uninitiated, fibroids are benign tumors. Please don't let the word tumor alarm you in this instance because it does not reflect malignancy. And they grow in the wall of the uterus, outside the uterus, or most importantly, within the setting of infertility and infertility treatments inside the cavity of the uterus. And by far, number one, when it's in the cavity, it needs to be removed. The dilemma arises when fibroids are in the wall and they're growing large. And although they might not be impacting the cavity and therefore potential implantation, when they're over 5 centimeters in diameter and they're enlarging the uterus, there is some data to suggest they're impacting the success of fertility treatments. Bear in mind that most women with fibroids don't even know they have them and they get pregnant. But when fibroids are large and they're symptomatic, so that individual is having heavy, painful, difficult periods, she's feeling abdominal pressure, she's feeling pushing on her bladder, resulting in frequent urination, she's having painful intercourse. Right there, you have a series of criteria that your gynecologist would use to remove the fibroids, irrespective of their impact on fertility. If those symptoms aren't occurring and the fibroids are in the cavity, yes, you want them removed. If the fibroids are large and over 5 centimeters, and maybe there's a lack of success to infertility treatments, it might be at the point where the risk-benefit analysis in that latter instance would be to remove the fibroid. And in the hands of a minimally invasive gynecologic surgeon, and we deal with, or we work with, or collaborate with a lot who are really good, the risk-benefit analysis would probably favor when the fibroid's big, even though it's not impacting the cavity, even though it might be asymptomatic, it might be worthwhile seeing one of those surgeons to do the procedure. It says here, did you know we have acupuncture right in our Waltham Center? I assume that's coming from one of my people. And so, yes, I did know that, but thank you for letting everybody know. Can you explain what, quote, hatching, close quote, is, and is that more successful? Okay, assisted hatching is where you have an embryo and you thin out the outer layer of the embryo. That outer layer is what is known as the zona pellucida. Okay, When you are transferring embryos at the cleavage stage of their development, which is day 3, some data would suggest by doing the assisted hatching, you're improving the ability of that embryo to implant into the uterus. Admittedly, and you're going to hear me say this a lot, for every study that suggests it makes a difference, there's 2 studies that says it doesn't. But it doesn't harm things when it's done in the right hands. And certainly at Boston IVF, it would be done in the right hands. Embryos that are being transferred later in development, those that are called blastocysts, that are being transferred on day 5 of their development, are often already hatching on their own, but there's no data to suggest that's going to give you a higher rate of success than an embryo that hasn't yet hatched. It just reflects that it's at a more advanced stage of development, but not necessarily going to give you a higher pregnancy rate. This is from an individual producing sperm. I have sperm normal forms, 3%. So that's called morphology, and I get into it in a second. And the individual is referencing that this is lower than the 4% that's considered normal. My wife and I have been trying to have a baby for 8 months, but we have yet to be successful. What is the chance here? Do I need to take any supplement or medication to improve that number? Okay. This is really a question for a urologist, which I am not. I'm a gynecologist. However, we work with the urology specialists a lot. And classically, if the parameters of the semen show a normal concentration of sperm, which you're suggesting you have, a normal motility to that sperm, which you're suggesting you have, and a morphology, the percent of the sperm that are normally shaped, if the other parameters are normal, 3% is totally okay. So when you see the lab say 4% is normal, it's not that exact. It's nowhere near that exact. Much more importantly is the concentration and the motility. And a 3% morphology is a subjective test. So if your partner has not been evaluated, it's time, if you've been trying for 8 months, especially if the female partner is over the age of 35, to be evaluated for your fertility issues, because in my opinion, it's doubtful that the semen parameters that you're referencing are playing a role. And I don't know of any perfect multivitamin that an individual should take to enhance their sperm counts. So it's basically what your primary care physician has told you for years. Don't smoke cigarettes. And by the way, that's the #1 toxin that's going to impact the efficacy of sperm to be good. #2, eat a well-balanced diet. #3, exercise regularly. #4, don't smoke pot. We really don't know the role of edibles, and so I can't reference any data, but I can say that marijuana will impact sperm motility. But anyways, well-balanced diet, no smoking, don't drink in excess, exercise regularly. Again, you just heard what your primary care physician's been telling you for years. And I wouldn't be worried about that 3% morphology if the other parameters are good. And I would, undertake an infertility evaluation because it doesn't look like the sperm is playing a role. What are some causes that breakthrough bleeding through medications could occur when prepping for a frozen embryo transfer? Okay, so again, for those who are uninitiated, one of the ways in which an embryo can be transferred is to prepare the uterus and the uterine lining for the upcoming pregnancy that is to result from the transferred embryo. So a classic way is taking hormones that simulate a menstrual cycle. So one takes estrogen, typically for about 2.5 weeks, to make sure it's thickening. And by so thickening, it's creating a pregnancy bed. If an individual, while they are taking the estrogen, is having what's called breakthrough bleeding, they're having bleeding that one would not expect, first of all, you'd want to make sure there's no anatomic issue. Well, very, very likely that's already been investigated because a uterine cavity assessment has been done. And classically, the way these uterine cavity assessments have been done is either through an imaging test after dye has been flushed into the uterus, or a telescopic instrument in the office is looked at, is passed to the cervix and the uterus was looked at, or an ultrasound with water shows us an interface and the uterine cavity. So that likely has been done, and therefore there isn't an anatomic issue. So then, why would you have breakthrough bleeding? Well, sometimes to synchronize the development of that uterine lining so one area doesn't outpace another, some individuals might need a higher dose of estrogen. Or, said in a different way, they might need the estrogen to be delivered differently. We all metabolize medications differently. So if an individual is taking estrogen in preparation for an embryo thaw, that individual, if it's takes it orally, might not absorb it as well through their gastrointestinal tract, and they might do better with transdermal or patch of estrogen or a vaginal suppository. So basically, by changing the mode of estrogen or increasing it, you start to stabilize that uterine lining. You increase that synchronous development and alleviate that breakthrough bleeding. This question from this participant, excuse me, is a tough one. It says, I am 41 with a low AMH, and as you guys heard me say, AMH is a hormone produced by all the growing eggs that sensitively predicts one's response to treatment, and ultimately hope to have 2 children. I'm wondering if doing a fresh transfer on the first IVF cycle might limit my ability to have a second child in the future. Should we try to do multiple cycles of IVF to bank embryos first? Okay, tough question. In the end, being age 41, which I would love to be, don't take that personally, I would love to be 41, but being age 41 already often precludes one, if they're starting later in life in their reproductive years to build their family, precludes one from having a big family. So that's one issue, irrespective of the AMH. Add on top of that a low AMH level, it's going to be difficult to bank embryos. And the better part of valor, most commonly, but certainly discuss with your doctor, depending on the AMH level, depending on the ultrasound that counts the follicles growing on your ovaries, and depending on other hormone tests, very likely the best approach is to try to get pregnant, as opposed to banking embryos. That could be very difficult to do. And much of this algorithm would also be based on whether or not insurance would let you bank embryos, which typically they do not. So, in the effort of full candor and as an advocate, I think it's best, if indeed the AMH is low at age 41, to try to conceive as opposed to banking embryos. But yes, would that fresh cycle inhibit perhaps your ability to build your family in the future? Yes, you're going to carry that baby for 9 months. You're going to breastfeed it for 12. And yes, it's going to be harder to get pregnant in the future. And I have many individuals who have 1 child who start at that age. Some have 2, some have to switch to an egg donor. But I would want you to discuss with your reproductive endocrinologist, does it appear that it would be viable at this point to be able to bank? And oftentimes it is not. Hold on. I'm starting my first IVF cycle. Do I have to do a short period of birth control, or am I able to have my cycle run normally and do the IVF cycle with that? Either one can be done. It's based on what's the best protocol for you. Without getting deep into the weeds of the biochemistry of an IVF cycle, some individuals, based on their age and their hormone levels, will benefit from a birth control pill lead-in before they start the injections. Others will not benefit from that, and you won't need to. The individuals who tend to respond better to the birth control pill lead-in tend to be younger, have higher ovarian reserve tests, and you need to kind of suppress the hormones with the birth control pill in the bloodstream so that the hormones that you take have a better ability to synchronize and develop the group of follicles that you're getting ready to retrieve. So it's going to be dependent on what looks best for you. Great question. I love this question. Is PGT typically covered by insurance if it's medically necessary? Parentheses, example, known inversion, close parentheses. Okay, folks, so I keep talking about PGT, pre-implantation genetic testing. What are we testing? Well, when it's PGTA, you're testing for chromosomes. What are chromosomes? Every cell in our body has 46 chromosomes. It's where our DNA is packaged. And within each cell, there's 23 pairs. And essentially, within each pair, one chromosome comes from our mom, one chromosome comes from our dad. So to make a normal human embryo, the eggs need 23, the sperm need 23. Typically, sperm always have 23, but women, as they get older, the reason there's a higher rate of infertility and the reason there's a higher rate of miscarriage, which is another form of infertility, is more of the eggs they produce and therefore more of the embryos they produce have an abnormal number of chromosomes. So PGTA is where you check the chromosomes of the embryos. You freeze the embryos, you wait for the results. Okay, this individual is referencing a known inversion. That's typically found within the setting where a couple's infertility is due to multiple miscarriages. And you check with routine blood tests how that individual's DNA or chromosomes are packaged and their blood cells. And an inversion is where there's a normal amount of DNA. So that individual is clearly normal, but it's packaged in such a way that when the sperm are formed, so that partner may have the inversion, or when the eggs are formed, that partner may have the inversion because it's rearranged in a way that it's difficult for either eggs or sperm to have a normal amount, and they keep producing these abnormally structured gametes that cause abnormal conceptions that miscarry. So that's how we wanted to teach people what inversions are. It occurs in 1% to 2% of couples suffering from recurrent miscarriages. And yes, it's a medical indication for the coverage of PGTA, as it should be, because it's clearly medically necessary. And it's typically preceded before you start the treatment with the genetics consult, going over the risk-benefit analysis of doing the PGTA approach. I've read that frozen embryo transfers are more successful, especially for certain racial groups, than fresh transfers. Assuming this is true, why are fresh embryo transfers still the standard first course of treatment? Well, frozen, great question, well-read individual. Frozen transfers are more successful for individuals who produce a lot of embryos. So by producing a lot of embryos, you can watch them grow, you can watch the best and freeze them. And typically for individuals who have a good response to treatment, who produce all these embryos that you can freeze for future thaw, they have very high estrogen levels, meaning hormone levels, during their treatment. And that high hormone level, through biological means, is going to decrease to a certain extent the success of the fresh transfer. So that patient is going to do better with a cycle where you thaw an embryo, typically either with a sophisticated use of estrogen, progesterone, the hormones that mimic an ovulation cycle, or timed with ovulation. Yes, that thaw cycle will be more successful. The classic approach to IVF is often referencing individuals who don't have a robust response, who don't have really high estrogen levels, who don't produce a lot of embryos, who don't have enough to freeze, so you have to get them in fresh. And for that individual, a fresh transfer is more successful than frozen, because you're not going to get enough embryos to freeze. Plus, during that fresh cycle, the estrogen levels aren't really high. This individual is asking how to know which option, intrauterine insemination versus IVF, is the best. It's based on age and diagnosis and cause of infertility, which is the same essentially as diagnosis. Meaning this, a quick tutorial. When individuals come in for an infertility evaluation, defined for couples in which the individual identifying as a female, for those individuals, they've been trying for 6 months, they've been unsuccessful, that's infertility. If they're over the age of 35, if they're under the age of 35, it's 12 months. Okay, that's infertility. They see the reproductive endocrinologist. He or she is going to put them through a series of tests. They're going to look at the ovarian reserve assessment. Those are the hormone tests that reflect how well or not an individual is predicted to respond to treatment. They're going to look at an anatomic survey of the uterus and the tubes, making sure the tubes are open, because 25% of couples presenting with infertility is due to tubes that are blocked. They're looking at the uterine cavity. 5 to 10% of couples, they're coming in with infertility because there's abnormalities in the uterus that need surgical correction. It could be a congenital abnormality. It could be a benign tumor. It could be scarring from previous procedures. 25%, all the tests are normal, and that's called unexplained infertility. And 40 to 50%, and I hope you weren't perfectly counting here, folks, because it didn't add up exactly to 100%, because there's overlapping diagnoses, but 40 to 50% is due to the male. Okay, so IUI is not going to work well for male factor infertility, because you need to get the eggs out, i.e. IVF, get the sperm in. So IUI wouldn't work there. If the tubes are blocked, IUI, intrauterine insemination, where you're processing the sperm and flushing it through the cervix and into the uterus. For instance, in the natural act of intercourse, 100 to 300 sperm make it into the tubes to fertilize an egg. With intrauterine insemination, it's 1 to 3 million. Well, IUI is not going to work if the tubes are blocked. And that's 25% of the cause of infertility. And as individuals get older, particularly the classic heteronormative or heterosexual couple who are the female partners over 35, IUI will work if things are unexplained, meaning periods are regular, tubes are open, sperm is normal. It might work, but you wouldn't want to do more than 2 or 3 cycles. In other words, classically, if you have an individual with unexplained infertility, which just means they're not getting pregnant, doesn't mean if it's unexplained and all the tests are normal, it doesn't mean you can't get pregnant. It means you're not getting pregnant. And the purpose of IUI, often given with a medicine to enhance ovulation, is to improve the process at every step, because you don't know what else to treat. You treat everything. You take a hormone such as Clomid, which is a pill, or letrozole, which is a pill, to enhance ovulation. You come in for blood tests and ultrasounds. And the day that it's identified that it's time to ovulate, you take a trigger shot, so you time it better than nature. And 36 hours later, you do an intrauterine insemination. That's where both individuals come in. The sperm is concentrated in a syringe and flushed through the cervix and into the uterus, increasing sperm delivery. So if you're calling it unexplained, you treat everything, the ovulation, the timing, and the sperm delivery, and it helps. And it's certainly more helpful for instance, heterosexual couples in which the female partner is under the age of 35. Over the age of 35 or over the age of 38, you wouldn't want to do it too long. But you have to make sure the tubes are open, and you have to make sure the semen parameters are good, and you have to make sure the uterus is okay. So you have to do a full evaluation to decide, number one, are you a candidate for IUI, and how many should you do? I will be starting letrozole soon as I ovulate irregularly. Parentheses, my cycles can be very long, so doctor is concerned by the time I ovulate, it's not a good quality egg. Close parentheses. Is there anything I can do to increase the chances of letrozole working quickly and getting pregnant? Well, if the ovulation is irregular, due to something you've heard me mention many times tonight, the polycystic ovarian syndrome, yes, there's data to suggest if it's from the classic polycystic ovarian syndrome, which is often associated with elevated insulin levels and kind of like a pre-diabetic state, not a diabetic state, but a pre-diabetic state, letrozole will work better, and there's a more enhanced ovulation, and there's potentially a healthier pregnancy if you combine that letrozole with what's called an insulin sensitizing agent, classically a pill called metformin or glucophage. So to answer your question, if that's the reason you're taking the letrozole, yes, taking glucophage or metformin will help the letrozole. If the irregular ovulation is due to the fact that it's just irregular ovulation, then there's no real adjunct that I can think of that would necessarily help the letrozole. Certainly for patients or individuals who don't have the polycystic ovarian syndrome, but may be overweight, and I am not at all trying to sound judgmental, and that morbidity is causing the irregular ovulation, weight loss and exercise might help as well. Excellent question from Courtney. I conceived my son after 1.5 years of trying. After trying for 10 months with second child, I was recommended IVF. It is a large expense for us, and I am wondering the chances of conceiving naturally again are, I'm going to be 38. Well, first of all, there's a definition of secondary infertility within the context of this description. And secondary infertility is basically a prolonged time to conception without success in your age group defined as more than 6 months. And it sounds like there was an element of primary infertility because you described it as 1.5 years with your first child. Congratulations, by the way, on your son. That's awesome. So yes, an infertility evaluation should be done. I'm not quite sure it has been, but the point is, for instance, men, as men get older, semen parameters can change. And don't presume that your infertility is just because you're getting older. You want to make sure that that semen is still normal. And if it is not, yeah, you have to either treat that or you need to do IVF because the sperm has changed as the individual producing that sperm has gotten older. So that's number one, do an evaluation. That evaluation, as I said earlier, will include an anatomic survey. Make sure the uterus and tubes are okay. So let's presume, because you have proven your ability to get pregnant and deliver, let's presume now you're 38, it's taking a long time. So let's presume all the tests are normal. What does population-based data say? Well, population-based data would tell us that once you've gone 6 months of well-timed, concerted, monogamous attempts at conception, your chances on your own per month of achieving a pregnancy that would lead to a live birth is less than 5%. Now that sounds alarming, but that's what the population-based data shows. We're all anecdotes, and it might be better than that. The problem is the individualized window of opportunity to build your family is narrowing because you're 38. And the purpose of the IVF is to expedite this process so you can optimize that window of opportunity to build your family. Meaning it doesn't mean you have to do it, but if population-based data is showing you a less than 5% chance per month, you may want to, unfortunately, make that expense to achieve your dream of building that family, again, within that narrowing window of opportunity, but make sure a full evaluation is completed. How long is the IVF process from our first consultation to the finish? A classic IVF cycle is where one comes in to the office and a history is taken and the tests are undertaken and a follow-up visit is scheduled. What are those tests? Well, the tests essentially are based on the menstrual cycle. Number one, the ovarian reserve assessment, which is a combination of blood test, ultrasound. Those tests are going to be done on the 3rd day of a menstrual cycle. The anatomic survey of the uterus and tubes is going to be anywhere between days 5 and 12 of that same menstrual cycle. And certainly the semen analysis can be done at any time. And there's a follow-up visit, so that's a month. Then you're going to see the doctor for a follow-up visit. And if IVF is required, it might not be IVF that's required, but if it is required, it typically takes a month to start that process because the patient has to become an expert. They have to learn how to take the medications. They have to have those medications ordered and make sure everything's in place before they start. And particularly for those individuals who have insurance coverage for treatments like IVF, the rate limiting step is the insurance, because in this world of COVID or post-COVID that we're living in, insurance companies, like many of us, are working remotely, they're understaffed, and they're taking longer, and the rate limiting step usually is insurance. In other words, a month of testing, a month of waiting for insurance approval, or a month of waiting to become the expert before you start the IVF process. And I actually tell my patients that at the first visit, because I do empathize and recognize how long it has taken for that couple to even get into my office, either because they've been trying a long time and haven't wanted to see a reproductive endocrinologist. And added on to that is the wait that was necessary to see the doctor due to his or her schedule. In my particular case, my schedule. So I tell patients, I give them the expectations in that first visit because I think patients, understandably, are under the impression that this is going to go right away. And there's no such thing when it comes to infertility as the patient. Understandably, everybody is inpatient, but you should expect 2 months before you start the treatment. So I think that's a good place to stop because we've now gone about an hour. And I think they were great questions. Actually, we certainly have a well-educated group, and I hope folks found it helpful. Bear in mind, I know my group's name is Boston IVF. Not everybody needs IVF, but whatever you need or whatever is required, the intent is to assist you in building your family, however that family might be defined. Or it's meant to preserve your fertility for those individuals who might be facing medical issues, requiring them to preserve their fertility either through eggs or with embryos based on the presence of a partner or the utilization of donor sperm, so that they can optimize their chances for the future. But the intent is always to help. Yes, It can feel like an arduous process. The best advice I can give individuals, don't put so much pressure on yourself. We do everything we can to take that pressure off you, provide services to help guide you, and again, with the common goal of building a family. Okay, thank you everybody for joining. I hope everybody has a beautiful summer night. And once again, as always, I'm honored to participate in these discussions. Have a great night.